Hello friends, welcome to Shri Netralaya. In this video, we will see managing a very hard cataract with pseudo exfoliation, mid dilated pupil and comparatively weak zonules. Anterior capsule is stained with trypan blue. A dilating agent is used, but this is a tonic pupil and not responding to mydriatic drugs. Anterior chamber is formed with viscoelastic. To manage such cases, it is important that you have a very stable chamber and visco must be utilized meticulously. Do not overfill the chambers. I usually use cystitome to perform CCC in all cases, but you must have a Rexis forceps standby in case needed to avoid extended Rexis. Here you can see the cortical material is calcified, so chances of running away Rexis in such scenarios is less. As I am performing my hydrodissection, I can note the nucleus is separated and it can be rotated well. Such sign of subtle changes which happens during hydrodissection should be noted in the anterior chamber and the movement of the nucleus is noted. Anterior chamber is formed with viscoelastic and anterior capsular flap is taken out as it may cause hindrance in the visibility. Here I am using infinity with a torsional power and if needed a longitudinal power also. So my intelligent phaco is on. So while I have a good grip of the nucleus, the longitudinal phaco also comes into the effect. The first job is very important. You must bury the tip of the phaco probe nicely and then have a good hold of the nucleus and then divide it so that you get a full through and through pass and your nucleus is divided into two heminuclei. Sometimes, as in this case, the division may not be complete and you have to rotate the nucleus 180 degrees so to complete the division. In small pupil cases, it is crucial to have a slightly longer left hand instrument as a dialer or a chopper. Here I am using 1.5 millimeter dialer and that helps me to rotate the nucleus, divide it and to manage the pupillary margin for better visibility in case needed. Here the pupil is small, so definitely I have to pull the pupillary margin to one side whenever needed. Once you have a small piece of nucleus divided, take it to the pupillary level and finish it off there. This way, you do not cause any pressure on the zonules and you can finish off each piece separately. These small particles which shoot into the anterior chamber cause much of a endothelium damage and those type of particles of nucleus should be taken out immediately as soon as they come out as they cause more of a endothelial damage. Once the nucleus is half divided, the anterior chamber is filled with viscoelastic again and remaining half of the nucleus is rotated in a position so that we can take out it in a comfortable way. Now you can see the pupil is hardly 3 to 4 millimeters, but it is not a problem. My visibility is not bad. My pupil is, though small, manageable with my left hand instrument. So again I will go in, hold it and slowly make more number of pieces, smaller pieces, take out each piece separately, leave behind the large chunk of the nucleus in the bag and finish off each piece in the pupillary plane or slightly sometimes maybe in the anterior chamber. This is an unedited video till phacoemulsification. After that, I have cut short the implantation of IOL as it may be boring to observe such long surgery. Anterior chamber is formed with visco and IOL is injected in the bag. This type of small pupil cases, peripheral bag is not visible and do not play around the cortical areas where zonules may be weak. So as soon as you are sure of your bag being clear of cortical material, just implant the IOL. Small fibers may be remaining in the peripheral areas, they can be taken out after implantation IOL also. Hope this video will help you in managing your next case of very hard cataract. Thank you and good day. Do subscribe to our YouTube channel Dr. Pankaj Lande for more such exciting videos.